Hello, I'm Shelley Paul, and I am going to be recording and presenting my Plan, Do, Study, Act change project for Nursing 451. The issue identification portion is, and the quality problem I identified is that many patients are not utilizing the benefits of a hospice service at end of life. According to Cagle et al., only 52.4% of patients are utilizing hospice benefits, which means approximately 1 million will die without the care of a hospice provider. And this is kind of special to me because I did lose my sister at age 48 from colon cancer. And we did use the service of hospice. And I cannot tell you, it was wonderful. And I will espouse hospice to anybody, I speak to because of my experience. The Joint Commission per se does not have a specific area for hospice or end-of-life care, but the standards throughout the other areas in which hospice would fall under would be medication safety, the right patient identification, and fall prevention. And according to the American Nurses Association, hallmarks of end-of-life care include respect for patient self-determination, non-judgmental support for patients, end-of-life preferences and values, and prevention and alleviating of suffering. And this is going to satisfy the student learning outcome number 8. Quality variance. There is no expected performance regarding hospice utilization. Ideally, all individuals who have less than 6 months to live would use hospice services. But as reported earlier, only 52.4% are utilizing this benefit. And within the clinical study or settings that I spoke to, and the statistics are maybe a little bit more above that. I would say maybe about between 55 and 60% out in the actual clinical setting are the patients are using this benefit. The root cause analysis. In speaking with multiple hospice providers, palliative and hospice healthcare professionals, the root cause of why patients and families are not utilizing the benefits of hospice are mostly due to fear and lack of education. Another cause is a family not understanding their loved one's wishes when they say, "I'm tired, I don't want to do this any longer." And this is something else. Patients and families, it's very emotional. And when a patient says that, the family thinks they're literally just tired and they just need more rest. But what the patient is actually saying is that, "I am ready to die, let me go." The scope. The scope of the problem is quite vast, and the problem will be getting much worse if something is not done. The largest generation, which are the baby boomers, are aging and will need additional medical care. By the year 2030, all baby boomers will be at least 65 years old, and through the 2020 census, policymakers are going to be making decisions based upon this. And this is through the American Census. And the stakeholders involved, basically, who is this going to affect? And basically, it's going to affect everybody, because when you're a individual is at the end of their life, and if they're not utilizing the hospice benefits, they're going to be in and out of the hospital. It's traumatic for the patient, it's traumatic for the family. Whereas if prior arrangements had been made and a hospice provider had been selected, in that situation the patient could be comfortable and they could alleviate a lot of that excess suffering. Solution. The root causes being fear and lack of education leaves little room for solutions. Fear of death is a normal fear, and I do not feel there's a solution for this. It's a normal response when a loved one is dying. Education, on the other hand, can be improved upon. If only 52.4% of people are utilizing hospice benefits, that means 47.6% of patients are not, and it would be because they do not know the true benefits of hospice. The solution would be to devise a way to help families and patients understand why they would want to use a hospice services. And so education, while what we have out there right now is good, but I just don't think it's doing justice to what hospice services can actually benefit the patient and family. Solution implementation. In researching how education is presented to a patient and or to the families, a typical scenario is as follows. Patients are in the hospital and they've found out the treatment for their condition is not working, or they've been just diagnosed with a life-threatening illness in which they have 6 months or less to live. And if they're in the hospital, the palliative hospice team will come and speak with them and explain the options, what they have. And they'll probably, give them a brochure. And then the patient's family will go, they'll read the brochure, they'll look at the website, and then they're expected to make a decision based upon that. A solution implementation, to me, the solution would be to continue to use these education pieces, but add to them a meeting with the families of deceased patients who have used the hospice services and had a favorable outcome. And when I mean favorable outcome, I mean that their loved one was able to die in peace, that it wasn't traumatic, in and out of the hospital, but it was in a loving environment with loved ones around them. Because a palliative hospice team can only do so much. And having prospective clients meet and hear the stories of families who have used hospice care for their loved ones at the end of their life may have more of an impact on their decision. Emotions are high during this time when families are in the hospital and told this information, and it's a lot to take in, for a family and a patient. The development and integrity of interdisciplinary education continues in hospice to teach strategies and techniques for effective communication, expert teaching, authentic relationship building, and building teams would ultimately improve family, caregiver, and patient outcomes. This satisfies student learning objective number 1, and that is demonstrate the knowledge of the leadership responsibilities of the registered nurse at all levels of healthcare system to facilitate high quality, low risk patient care. The analysis. The measures that would be analyzed would be the increased percent of individuals opting to use hospice benefits at end of life. The financial measure would be measured over time. The patient on hospice would not be using inpatient services / emergency room as frequently, and the end of life costs would be reduced. And Medicare talks about greater use of hospice and palliative care with their lower cost per patient, offers the possibility of expense reduction to the Medicare system. And right there, the Medicare system is very burdened. And as I had mentioned, the scope of the problem is baby boomers, 65 or older. It's going to be a real strain on the system. And I think something needs to be done to alleviate that. The next steps. What I would recommend doing is creating a committee of non-medical professionals comprised of family members who have used hospice services within the last year. I would like it within the last year because the emotions, the experience are fresh in their mind. This committee would be completely volunteer. So they're doing it because they want to. They want to share the message of, of the importance of hospice and the support they received and their loved one received. The committee would be composed of 7 to 10 members who would be willing to meet prospective hospice clients at the location of the client's choice. And the members must be willing to be open and vulnerable and just to share their story. Once the family caregiver was confident that they shared an authentic relationship with members of the hospice team, they could handle a certain amount of tension when making joint decisions. This was Ellington also. And when a family feels that they're not being sold on a service, but that it is something where people generally care. And I'm not saying that the hospice slash palliative services don't care, but when it's sometimes when it comes from almost a peer, somebody who's going through the same thing they're going through, it might be a little bit more effective on the education piece. And here are my references. And I hope this will, help. I don't know whether there will be a change, but um, since this is a leadership class and we're, talking about change, um, I hope this could be an idea somebody could put into practice. Thank you.